Chapter 44, Tuberculosis and Simple Ulceration of the Bladder, Tuberculosis of the Prostate and Seminal Vesicles. Tuberculosis of the Bladder. Etiology. Tuberculosis of the bladder is almost always secondary to lesions in the kidney or in the prostate. It may be secondary to adjacent tuberculosis in other organs, but this is most exceptional. Thus, Violer and Chalier report 3 cases of rupture of tuberculous adnexa into the bladder. At least 9 out of 10 cases of bladder tuberculosis are secondary to kidney lesions. Age: G. Walker collected 475 cases of bladder tuberculosis, the great majority between the ages of 15 and 40. Pathology: distribution of lesions. The lesions of vesical tuberculosis begin about the ureter if the disease descends from the kidney, about the bladder neck if the invasion is from the prostate. But when the case is first cystoscoped, there is often a general distribution of the lesions about the trigone and perhaps about the rest of the bladder, which prevents a definite diagnosis from cystoscopy alone without the aid of ureter catheterization. If there is mixed infection, the whole bladder may be inflamed. If not, even though the greater part of the organ is inflamed, there are usually regions in which the normal mucous membrane may be seen at some parts of the vault of the bladder. The tubercles appear as minute raised areas the size of a pinhead surrounded by an area of congestion. They are usually grouped together over irregular areas of the bladder wall, while between them the mucous membrane is red, swollen, and velvety. Thus, a diffuse vesical tuberculosis gives the whole mucous membrane a velvety appearance. Although the tubercles may be seen, and sometimes even felt, through the unbroken epithelium, the initial deposit occurs, as Copland has justly remarked, not in the epithelium, but in the subepithelial connective tissue. The tuberculous ulcer is singularly round and discoid. Even the confluent ulcers rapidly lose the isthmus which at one time partly separated them, and quickly assume a roundish outline. The floor of the ulcer is shaggy, of a dirty yellowish color. It is uneven in contour. Commonly, the ulcer does not become larger than 1 or 2 centimeters, or about the size of a 5-cent piece. The floor of the ulcer is the submucosa, containing considerable embryonic tissue. In some instances, and at a few points in any ulcer, the muscular wall may be exposed. I think extension into the muscular wall must be rather infrequent. The edges are elevated and slightly undermined, hard to the touch. Copland. The above description, written from the point of view of the pathologist, is entirely in accord with the clinical findings. I have never known perforation of the bladder to occur spontaneously, but I have twice known perforation to follow cystoscopy. The great irritability of the bladder, its characteristic inability to retain more than a few ounces, is due at first to the great sensitiveness of the tuberculous lesions, later to an actual infiltration and contracture of the muscular walls. Individual lesions may heal while others progress. The removal of the tuberculous kidney is usually followed by the healing of the tuberculous bladder lesions in a few months if they are recent, in a few years if ancient, or fed by tuberculous prostatitis or stricture. Direct extension of the inflammation to the posterior urethra is common. Extension to the anterior urethra is rare. I have seen it but once. Urethral stricture and periurethral abscess are rare complications.